The pooled analysis and longer-term follow-up of Ibrutinib in mantle cell lymphoma. And I think the bottom line, the underlying theme is earlier use equals better outcome, not just with respect to progression-free survival, probably overall survival, but also toxicity. Earlier use of the drug, you actually get fewer side effects. Not the sort of cardiac type toxicity, but infections, hematological toxicity, less the earlier use of the drug. So I think it's just becoming very clear that as the most effective therapy there is, that moving it earlier into the treatment algorithm is clearly what we should be doing, and obviously frontline is the next place. There are a lot of BTK inhibitors. I've now used 5 different ones. We've got another 1 or 2 we might be using in the next year, probably will be using in the next year. They're all broadly the same from a response perspective, different side effect profiles. And as we use them earlier, everybody relapses. When they relapse, depending on where the BTK inhibitor has been used in the treatment algorithm, dictates how easy it is or not to treat. So using it earlier, retreatment is easier, but it becomes increasingly difficult. And Venetoclax is an interesting drug. We don't have access to that at the moment in this country. Combinations are interesting, but CAR T-cell, as you rightly say, is a potentially exciting innovation. It looks very active in diffuse large B-cell lymphoma. There is a trial ongoing in the States right now in mantle cell, and most of those patients are post-Ibrutinib. I think they're all post-Ibrutinib, and we will see. It's the obvious thing to do next. There isn't an obvious drug that's coming. There are lots of things in the pipeline, but there's nothing yet that kind of looks extremely promising beyond the Venetoclax. So CAR T-cell is the sexy thing right now, and I think that's what we're going to be exploring over the next few years, and we'll see whether that holds promise.